Today is about understanding how each step of the CCM process helps us keep patients healthier, safer, and out of the emergency department. Every phone call, every care plan update, every referral follow-up is an opportunity to identify a problem before it becomes a crisis. The goal is to make sure our patients always feel connected to their care team, even when they're not sitting right in front of their provider. Our patients are managing multiple chronic conditions, seeing multiple specialists, taking numerous medications, and trying to navigate a very complex healthcare system. We may assume someone else is helping them coordinate their care, but often no one is. We become the bridge between visits and help patients stay on track before problems become emergencies. Chronic care management is one of the most powerful tools we have to support our patients between office visits. Most health crises don't happen when a patient is sitting in an exam room. They happen in the home when symptoms worsen, medications become confusing, transportation falls through, or a patient simply doesn't know when or who to call. By the end of this training, you will understand how patients are identified for chronic care management services and how to deliver the service in a way that meets CMS requirements while providing exceptional patient care and patient experience. We will review documentation expectations and billing requirements because if care isn't documented appropriately, we cannot demonstrate the work being done or the value being delivered to our patients. Most importantly, I want you to understand that every outreach call, every medication reconciliation, every education opportunity, and every barrier you help remove has the potential to prevent an emergency department visit, a hospitalization, improve quality of life, and help the patient remain independent for as long as possible. At the end of this training, my goal is that you leave with the understanding of not only what to do, but why it matters. Chronic care management is more than a phone call. It is proactive care coordination and population health management. The purpose of CCM is to support our patients and the people who love them. In doing so, we reduce the additional burden placed on our providers and back clinic staff. Every task we complete helps ensure that patients receive the right care at the right time in the right setting. When we follow these workflows consistently, we reduce suffering, prevent avoidable utilization, strengthen relationships with our patients, and truly put them first. Patients may not remember the care plans we complete, but they will always remember how supported they feel during difficult times from their CCM team member. CCM is proactive care. Instead of waiting for patients to become sick enough to need the emergency department or hospitalization, our goal is to identify risks early, intervene early, and help our patients stay healthier longer. That is the purpose of this program and the reason this work is so important. Every interaction you have is an opportunity to positively impact another person's life. Your intentional human connection can transform an ordinary patient interaction into a memorable patient experience. We aren't just making chronic care management calls. We're pouring hope, confidence, empowerment, education, support, and reassurance into our patients' lives. Our chart review gives us a window into a patient's health conditions, medications, hospitalizations, and social needs. But what we don't see is everything else they may be carrying. Your patient may have just lost a spouse. They may be struggling financially. They may be feeling isolated or overwhelmed. Today may be the hardest day they've had in months. We're not sure about all of those things before we call, but we do know this. Those few minutes we have the patient on the phone, we have an opportunity to make their day a little brighter and a little easier. Every call matters. You may be making your 10th call of the day, but your call may be the only meaningful conversation your patient has all week. Never underestimate what that means. People remember how we make them feel. Patients may forget every detail of their care plan. They may not remember every education point or medication discussion, but they will remember that someone cared enough to call. They will remember that someone listened. They will remember that someone treated them with dignity, compassion, and respect. These moments create memorable patient experiences, and memorable experiences create trusting relationships. Chronic care management gives us the privilege of building relationships with our patients over time. Our patients don't hang up the phone thinking, "Oh, I'm so glad my annual care plan was updated." They think, "Someone checked on me. Someone remembered me. Someone cared enough to call me." That's the experience we're creating. Every month, every patient, every interaction. Relationships are what change behavior and change lives. Every morning before you make your first phone call, decide how you're going to show up for your patients. Choose to be present. Choose to be curious. Choose to be patient. Choose to listen. And choose compassion over rushing, because patients can tell the difference. Our goal is for every patient to finish each interaction feeling heard, supported, valued, and more confident managing their health than they were before we called. That's what excellent care feels like. The most impactful interventions aren't always clinical. Sometimes they are remarkably simple. Remembering a grandchild's name, asking how a recent procedure went, following up on a concern they shared last month, celebrating that they've quit smoking, congratulating them for losing 5 pounds, remembering the name of their dog. Those small moments tell patients, "I remember you. You matter to me, and I'm listening." Those moments build relational trust, and trust changes behavior. Patients who trust us are far more likely to take their medications, keep appointments, call us when symptoms start, ask questions, and call us before going to the emergency department. That's where outcomes improve. Not because we completed another task, but because we earned our patients' trust. A single CCM call may influence whether your patient takes their medication tomorrow, whether they schedule that specialist appointment, whether they report worsening symptoms before they become an emergency, whether they stay engaged with their healthcare team, and whether they feel hopeful. Never underestimate the influence you have on your patients. Our goal isn't simply to complete a certain number of encounters each month. Our goal is to create meaningful opportunities to improve our patients' health, confidence, and quality of life. Every outreach is a chance to reduce fear, increase trust, build confidence, strengthen relationships, and help your patient feel supported. Because we aren't just checking boxes, we're building relationships that help people live healthier, safer, and more connected lives. The primary source of patient identification for chronic care management is the Johns Hopkins Adjusted Clinical Group Predictive Risk Model. In short, the Johns Hopkins model is a tool that helps us identify which patients are most likely to need extra support in the future so we can intervene early and keep them healthier longer. The Johns Hopkins ACG system uses information from all possible claims sources to predict the chance that the patient may have health problems, emergency room visits, hospitalizations, or greater healthcare needs in the future. This model looks at things such as medical conditions and diagnoses, the number of chronic conditions a patient has, the medications that they take, past hospitalizations and ER visits, age and gender, and how often healthcare services are used. It then assigns the patient a risk score. The score is a guide that helps direct resources to patients who are most likely to benefit from proactive care. Based on this score, patients are recommended for specific clinical programs and initiatives. The goal is not to predict exactly what will happen to the patient. The goal is to identify who might need help before a crisis occurs. It helps us focus our time and efforts where we can make the biggest difference. The ACG score helps prioritize outreach, but it does not replace clinical judgment. That's why we also accept provider and TCM referrals for chronic care management. ACG recommendations are reviewed quarterly and assignments are made on Monday.com. Monday.com is our source of truth, and it is updated monthly by our IT team with the most recent patient rosters. Once assigned, the CCM team member is responsible for reviewing the patient information, completing timely outreach, documenting progress, updating the status, and escalating concerns when needed. This is not just a task list, it is a patient safety and accountability tool. Accurate assignment helps us make sure high-risk patients are not falling through the cracks, that care is coordinated, and that we can measure productivity and outcomes fairly. If a patient is assigned to you and you believe the assignment is incorrect, communicate that with your lead and make sure the patient is reassigned appropriately if needed. The goal is simple. Every patient who needs CCM is assigned, every next step is clear, and every patient assigned to a care manager receives timely follow-up. Participation in chronic care management is voluntary. Before services begin, patients have to be educated on what the program includes, that only one provider can furnish and bill chronic care management services during a calendar month, that they have the right to stop participating at any time by notifying the practice, and that we will coordinate their care through a comprehensive care plan and provide 24/7 access to their care team. Patients must also be informed of any cost sharing associated with CCM services. Prior to completing and billing the initial comprehensive care plan, you may review the patient's insurance information in Athena to determine whether there is an indication of potential patient cost sharing. This allows you to provide accurate information during the enrollment conversation. Many of our patients will not have out-of-pocket expenses. Patients attributed to our ACO REACH receive a CCM cost-sharing waiver, and most Medicare Advantage plans also do not require a copayment for CCM services. After all questions have been answered and the patient agrees to participate, document informed verbal consent in the medical record before CCM services are initiated and billed. Not every patient will choose to participate in chronic care management, and that's okay. Participation in CCM is completely voluntary. Patients have the right to decline enrollment or withdraw from the program at any time. However, when a patient declines CCM services, our responsibility doesn't end there. First, notify the primary care provider by documenting the patient's decision in the VBC annual patient case. Next, include a note in the appointment notes section of the next scheduled office visit so the provider is aware CCM was offered and declined. This keeps the entire care team informed and creates an opportunity to revisit the conversation during a future visit if the patient's needs or preferences change. Then, determine whether the patient is willing to continue receiving periodic outreach, even though they do not wish to participate in CCM. Many patients decline because of the potential for cost sharing, but they still appreciate someone checking on them. If the patient agrees to ongoing outreach without participating in CCM, you may leave the patient on your list in Monday.com for care coordination, triage, and intervention activities that support our full risk population health programs. These encounters are not billable CCM services. Do not complete or maintain a CCM comprehensive care plan, and close each encounter using a non-billable code. During these outreach calls, continue to assess for changes in health status, reinforce the patient's care plan developed by the provider, identify barriers to care, provide appropriate education, coordinate services, and escalate concerns to the primary care provider when clinically indicated. Remember, declining CCM does not mean the patient is declining compassionate care. Our goal remains the same: to proactively support our patients, identify problems early, and help them stay healthier while respecting their choices. Every respectful conversation is an opportunity to build the relationship. As part of standardizing how we work across markets, the VBC SharePoint folder should be your first stop when you need current resources, workflows, templates, job aids, or program guidance. This folder was created to give everyone access to the same information, so we are not relying on outdated documents, old emails, or different versions of the same process. When we use the resources in SharePoint, we improve consistency, reduce variation, and make it easier for our staff to follow approved workflows. Before creating your own tool, checklist, or document, please check the SharePoint folder first. There may already be an approved resource available for you. This helps prevent duplicate work and ensures we are using the most up-to-date guidance. It is also important to avoid saving separate copies to your desktop or using printed versions long-term, because these can quickly become outdated. If a resource is updated in SharePoint, that is the version that we want everyone using. If you're unable to find what you need, or you notice something that seems outdated or unclear, escalate that to your leader so we can update the resource or add additional guidance. SharePoint should be a living resource that supports our team and helps us deliver consistent, high-quality care. The goal here is simple: one source of truth for standardized processes and better support for the patients and practices we serve. The CCM workflow may look lengthy, but every step exists because it prevents something from being missed. If we skip a step, a patient may miss a specialist appointment, fail to complete a diagnostic test, stop taking a medication, or end up hospitalized. The workflow creates a safety net around the patient. Before you begin your chart review, make sure you navigate to the Athena Quick View and verify Health Data Sharing is turned on. If it is not, make sure you select Yes and click Save. Verifying health data sharing might seem like a small task, but it allows us to access information from outside hospitals and providers. The more information our clinicians have, the better decisions they can make. Patients shouldn't have to remember every detail of every health encounter they've ever had. Health information exchange supports care coordination and access to outside records to ensure continuity, quality gap closure, and coding accuracy. You should also remember to review the Athena Personal Information section of the Quick View. Make sure the preferred language has been selected and review any interpreter needs the patient might have. You have to remember to hit Save when you're finished. You may need to refresh or go out of the chart and back in before records begin populating. On the right-hand side of the patient's chart, you can review outstanding orders. Providers order labs, imaging, and referrals because they need information to make clinical decisions or because the patient needs the support of a specialist. If the testing or referral never get completed, or the results or consult notes never return to the patient chart, the patient's care stalls. This step ensures that recommendations specialists make or lab and imaging results received actually turn into action. As you review outstanding orders, determine whether the associated results or consultation notes have been received. If the records have been received, verify they have been routed to the provider for review. Once the provider has reviewed the results, tie the results to the corresponding order and close the order to ensure the medical record accurately reflects the patient's outstanding orders. If results or consult notes have not yet been received, this should become part of your patient conversation. Confirm that the patient is aware of the outstanding order, understands why it was recommended, and knows when the provider would like it completed. This is also an opportunity to identify and address any barriers that may be preventing the patient from following through, such as transportation challenges, financial concerns, scheduling difficulties, or questions about the test or referral. Document any relevant updates from your conversation in the action note of the order. This creates a centralized source of the most current information, allowing the provider and other members of the care team to quickly understand the status of the order, any barriers identified, and the next planned steps. Remember, reviewing outstanding orders isn't just about closing tasks. It's about ensuring the patient received diagnostic testing, specialist evaluations, and treatments their providers have recommended. By proactively identifying barriers and helping patients complete these important next steps, you are improving care coordination, supporting better health outcomes, and helping prevent delays in diagnosis or treatment. One of the biggest barriers patients face is navigating the healthcare system. Scheduling, transportation, referrals, authorizations, and multiple specialists can become overwhelming. By tracking orders and following up, we're helping patients overcome those barriers and preventing delays in care. Before we call a patient, we should know their story. A thorough chart review prepares us to have meaningful conversations and demonstrates to our patients that we know them, we remember them, and we are invested in their care. It also prevents patients from having to repeat their medical history every time we speak with them. For long-established patients, review everything that has occurred since your last contact. For patients who are newly assigned to you, review at least the previous 6 months of their medical record to understand their recent health journey and establish a baseline. Start by reviewing any specialist consult notes and hospital or emergency department records. Pay close attention to changes in diagnoses, medications, treatment plans, or recommendations. These records often identify new concerns that should be discussed during your outreach. Then review the medication list and medication refill history. Medication adherence is one of the most important predictors of chronic disease control and one of the leading contributors to preventable hospitalizations. A medication that isn't filled or isn't taken as prescribed cannot work. Look for missed or inconsistent refills, medications that will soon require refills, or patterns that suggest adherence concerns. During your conversation, explore potential barriers such as medication cost, side effects, transportation, confusion about the regimen, or difficulty obtaining prescriptions. Then review the patient's vital signs to understand their baseline and identify meaningful trends. Review recent laboratory and imaging results for abnormal findings or changes that may require education, monitoring, or additional provider follow-up. Previous primary care visits can provide valuable insight into treatment changes, health literacy concerns, social determinants of health, access barriers, or challenges with self-management. Understanding these factors allows you to tailor your conversation to the patient's individual needs instead of taking a one-size-fits-all approach. Don't forget to review the patient information banner for open quality opportunities, including annual wellness visits, preventative screenings, immunizations, labs for chronic disease monitoring, and follow-up appointments. Quality measures are much more than insurance requirements. They represent evidence-based preventative and chronic care practices that improve health outcomes. Vaccinations prevent disease, screenings detect illness earlier when treatment is most effective, and routine monitoring helps us intervene before complications occur. Finally, don't just look at individual data points. Look for patterns and trends. You should always be asking yourself, is this patient getting better? Are they staying the same, or are they declining? Your chart review should help you identify concerns before the patient tells you something is wrong. That preparation allows you to ask more meaningful questions, intervene earlier, remove barriers to care, and deliver a truly patient-centered CCM encounter. When we understand the patient's story before we pick up the phone, we spend less time gathering information and more time making a difference. An accurate and up-to-date problem list is one of the most important tools in the patient's medical record. It provides every member of the care team with a clear picture of the patient's chronic conditions, helping ensure that care is coordinated, appropriate monitoring is performed, and treatment decisions are based on the patient's complete health history. As you complete your chart review, you may identify chronic conditions that have been documented by an external provider but have not yet been added to the problem list. When this occurs, and only if it is approved by your patient's provider, you may update the problem list so it accurately reflects the patient's current health status. But before adding any diagnosis, you must verify that it is supported by provider documentation. This may include documentation from a hospital discharge summary or a specialist consult note that clearly identifies the diagnosis by the ICD-10 submitted on the claim. When adding the condition, document the source of the information in the comments. For example, see hospital note dated 10/26/26, so there is a clear reference supporting the update. It is equally important to understand what not to do. Never add a diagnosis based solely on laboratory values, imaging results, medications, patient statements, or your own interpretation of the medical record. Care managers do not diagnose patients. Every diagnosis added to the problem list must be supported by documented provider assessment. Maintaining an accurate problem list improves patient safety by helping ensure chronic conditions are recognized during every encounter, reducing the risk that important diagnoses are overlooked during transitions of care, hospitalizations, referrals, or medication management. It also supports preventative care and chronic disease management by prompting appropriate monitoring, screenings, and evidence-based interventions. In value-based care, an accurate problem list contributes to more complete documentation of the patient's disease burden, supports quality reporting, and helps ensure the patient's complexity is appropriately reflected. Remember, your role is not to diagnose. It's to ensure that the medical record accurately reflects diagnoses that have already been established by a qualified provider. By keeping the problem list complete and current, you help every member of the care team deliver safer, more coordinated, and more proactive care. For some patients, these may be the only healthcare interactions they have this month. We may be the first person to identify worsening symptoms, social barriers, medication problems, or emotional struggles. Never underestimate the value of simply checking in. Patients will often tell us what matters most if we give them the opportunity. Open-ended questions help us uncover concerns we may never discover by asking yes or no questions. The goal is to understand what life is actually like for the patient. When you call your patient, if they answer, you can proceed with your CCM encounter. You should complete the assessment and triage, care planning, document your interventions and education, and any coordination of care that occurs. If a patient does not answer, you can leave them a voicemail if you're able and reschedule them for the following day. If the patient calls back the same day, you can reschedule and go ahead and complete that encounter. Make sure that if your patient is seeing specialists that you remember to update the care team and send continuity of care requests for medical records. Your documentation tells the patient's story. It allows other team members to understand what was discussed, what actions were taken, and what still needs attention. Good documentation protects the patient, supports continuity of care, and ensures everyone is working from the same information. Assessments help identify risks before harm occurs. A patient may not realize they're at risk for falls or a COPD exacerbation. These assessments allow us to intervene early and help keep our patients safe. Patients' lives change. Housing situations change. Caregivers become ill. Financial circumstances shift. Annual assessments help us identify barriers that might not have existed a year ago and ensure our care plans remain relevant. Many health problems aren't caused by disease alone. Lack of transportation, food insecurity, financial stress, and social isolation often have a greater impact on health outcomes than medical treatment. Addressing these issues is part of providing whole person care. We cannot address the issues unless we assess for the issues. One of the greatest strengths of our value-based care model is that we don't have to wait until a patient is in crisis before we intervene. A community care manager referral is appropriate anytime you or the primary care provider believe an in-home assessment, intervention, or additional support could improve the patient's health, reduce barriers to care, or help prevent clinical decline and avoidable hospital or emergency department utilization. If you believe a patient may benefit from an in-home visit, discuss the patient with your manager. Together, you can determine whether a community care manager referral is appropriate based on the patient's clinical condition, functional needs, and social circumstances. Patients who may benefit from a referral include those who are experiencing new or worsening changes, significant worsening of chronic disease symptoms, a recent hospitalization, observation stay, or rehab stay, frequent or increasing emergency department utilization, difficulty managing chronic conditions at home, medication adherence or medication safety concerns, functional decline, caregiver concerns, or barriers that make it difficult to access care. Remember, the goal is early intervention. Don't wait until a patient becomes unstable before asking for help. Community care managers are an extension of our care management services. They identify concerns that may not be apparent during an office visit or phone call. They're able to help patients overcome barriers with successful self-management. A timely referral can make the difference between identifying problems early in a home visit and avoiding emergency department utilization. When in doubt, ask. It's always better to discuss a potential referral early than miss an opportunity to provide additional support when our patients need it the most. Providers depend on us to identify issues between visits. We must communicate concerns efficiently and effectively so patients receive timely interventions. Strong communication prevents delays in care. These are some examples of findings that require immediate escalation and same-day intervention. Make sure you are reviewing any parameters and thresholds in your patient's chart, as they may be different from those listed on this slide. Effective communication is one of the most important patient safety tools we have. Every escalation should be documented in the patient's annual VBC patient case and pinned to the top so it is immediately visible to everyone involved in the patient's care. Using a single annual patient case keeps all updates related to the patient's care in one location. This provides important historical context for covering care managers, providers, and other team members when someone is out of the office or when care is handed off. It also reduces fragmentation in the medical record by preventing multiple patient cases for the same issue, where important updates can easily be overlooked. Maintaining one continuous annual patient case also supports our documentation standards and helps demonstrate coordinated team-based communication during NCQA patient-centered medical home audits. When escalating a concern, always communicate using the SBAR format. Situation: what is happening right now? Why are you reaching out? Background: what clinical history or recent events are important for the recipient to know? Assessment: what did you observe or identify? What concerns you? And recommendation: what action are you requesting? Do you need a provider review? Does the patient need an emergency evaluation, or is there another intervention? Using SBAR creates clear, concise, and consistent communication, allowing providers to quickly understand the issue and make timely clinical decisions. Finally, remember that sending a message is not the end of the process. Our goal is closed-loop communication. That means ensuring the message has been received, acted upon when appropriate, and that the outcome is documented. If additional follow-up is needed, continue tracking the issue until there is a clear resolution or handoff. Closing the loop helps prevent missed communications, improves patient safety, and ensures that no important concern falls through the cracks. Every escalation should end with one question: has the patient received the action or the follow-up that they needed? If the answer is no, the loop is not yet closed. Sending a patient case is not the same thing as solving the problem. Patients enrolled in CCM should never wonder who to call or when they'll hear from us again. Scheduling the next interaction creates accountability for us and reassurance and sense of trust for the patient. Before ending the call, the care manager must make sure the patient has their next visits scheduled. That includes the next CCM appointment, the next annual wellness visit, and a PCP follow-up appointment if one is not already scheduled. This is not optional. Every CCM patient should leave the interaction with a future touch point on the calendar, no exceptions. The reason this matters is simple. Scheduled follow-up keeps patients connected to the care team, supports proactive management, reduces gaps in care, and helps prevent patients from falling through the cracks between weekly outreach, wellness visits, and provider follow-up. Before closing the encounter, confirm the dates with the patient, document the appointments, and make sure the patient understands when and why we will be reaching out next. One of the most important compliance requirements for CCM is ensuring the care plan is reviewed and signed by the supervising provider at the appropriate times. While the care manager develops and updates the care plan, there are specific situations where provider review and signature are required. The first is the initial care plan when a patient is newly enrolled in chronic care management. This confirms the provider has reviewed and approved the patient's comprehensive plan of care. The second is the annual care plan review. At least once every year, the provider must review and sign the care plan to verify that it remains accurate, appropriate, and is aligned with the patient's current needs. In most cases, this will be the first care plan completed each calendar year. The third situation is when there has been a significant revision to the care plan. This happens often after hospitalizations or transitions of care when new diagnoses are presented. These are meaningful changes that require provider oversight. Finally, if the supervising provider changes, for example, because a provider retires and leaves the organization, or when care is transferred to another provider, the care plan must be routed to the new supervising provider for review and signature. Remember, provider signatures are more than a documentation requirement. They demonstrate active provider oversight, interdisciplinary collaboration, and compliance with CMS expectations while ensuring the plan of care continues to reflect the patient's current medical needs. One of our goals is to deliver seamless, coordinated care without overwhelming patients with multiple calls from different members of the care team. When a CCM patient experiences a hospitalization, observation stay, or discharge from a skilled nursing or rehabilitation facility and is identified as high risk for readmission, the patient transitions to the transitional care team. During this high-risk period, the TCM team focuses on time-sensitive interventions such as post-discharge outreach, medication reconciliation, scheduling timely follow-up appointments, identifying barriers to recovery, and reducing the risk of avoidable readmissions. While a patient is actively being managed by the TCM team, routine monthly CCM outreach should be paused. This prevents duplication of services, reduces patient burden, and allows each team to focus on their specific responsibilities while working toward the same goal. Communication between teams is essential. If you become aware that one of your CCM patients has been admitted to the hospital, placed in observation, or discharged from a skilled nursing or rehabilitation facility, and it appears that the TCM team has not been made aware of the event, notify them immediately. Early notification allows them to initiate timely interventions during this critical transition period. It's also important to remember that not every hospitalized patient receives the same level of TCM follow-up. Patients that are moderate or low risk for readmission generally complete the TCM process more quickly than high-risk patients. Once the TCM episode is complete and the patient is determined not to require ongoing high-risk TCM management, the patient will transition back to routine CCM services to ensure continuity of care and ongoing chronic disease management. The key takeaway is that we're never stepping away from the patient. We're coordinating our efforts so the right team is engaging the patient at the right time. Productivity expectations for chronic care management are outlined here. These benchmarks are designed to ensure patients receive consistent, high-quality support while allowing us to expand access to patients who can benefit from CCM services. Each care manager is expected to maintain an active panel of approximately 75 enrolled CCM patients. As patients disenroll, transition to a higher level of care, or no longer qualify for CCM, new eligible patients should be enrolled to maintain panel size and ensure continuity of care across our population. From a productivity standpoint, each care manager should complete a minimum of 56 initial monthly CCM encounters each month. These are the required monthly contacts that satisfy the expectation for ongoing care management. In addition, the overall productivity goal is 225 total CCM encounters per month, which averages to about 10 CCM encounters per workday. Total encounters include initial monthly contacts, follow-up calls, care coordination, patient outreach, provider communication, and other clinically necessary CCM activities documented through the month. These expectations help ensure patients are receiving timely interventions, chronic conditions are actively managed, and opportunities to prevent avoidable emergency department visits and hospitalizations are not missed. We also recognize that productivity expectations must be balanced with operational realities. Adjustments may be made for approved PTO, FMLA, onboarding, mandatory education, organizational projects, or other leadership-approved activities. Remember, productivity is not simply about making calls. It is about consistently engaging patients, documenting meaningful interventions, and delivering high-quality care that improves outcomes while supporting the success of our value-based care programs. Excellent documentation is more than a regulatory requirement. It's how we communicate, protect our patients, and demonstrate the care we've provided. Remember the rule. If it isn't documented, from a legal and clinical standpoint, it didn't happen. Always verify who you're speaking with before discussing protected health information. And if you're speaking with someone other than the patient, confirm there's documented authorization in the chart. Document as close to the patient interaction as possible while the details are fresh. Your documentation should be factual, objective, and free of assumptions. Record what you observed, what the patient reported, and what actions were taken. If information comes from a family member or caregiver, clearly identify the source. Every telephone encounter should tell the complete story: who you spoke with, why they called, your assessment, the education or advice you provided, and the follow-up plan. If a patient declines recommendations or faces barriers to care, document those objectively along with the education you provided and the next steps. One important documentation standard is the use of abbreviations. Because Complete Health does not maintain an organization-approved list of acceptable medical abbreviations, our expectation is that abbreviations are not used in clinical documentation. While abbreviations may seem faster, they can mean different things to different clinicians. What seems obvious to the person documenting may be misunderstood by someone reading the chart months later or during a medical emergency. Spelling out diagnoses, medications, assessments, and instructions creates a clear medical record that supports safe patient care, accurate communication among the care team, compliance with documentation standards, and a stronger legal defensibility. When in doubt, write it out. When communicating concerns to providers, use the SBAR framework to ensure your report is organized, concise, and clinically meaningful. This improves patient safety and helps providers make timely decisions. Finally, remember our documentation requirements when patient reports changing primary care providers. The workflow differs slightly for ACO REACH and Medicare Advantage patients, so follow the appropriate process to ensure attribution, communication, and care coordination remain accurate. Today we've talked about workflows, documentation, CMS requirements, NCQA standards, productivity, and clinical excellence. These are all important because they create consistency and sustainability, but none of them are our purpose. Our purpose is the patient on the other end of the phone. If every patient hangs up feeling heard, respected, empowered, and cared for, we've done far more than complete a care plan. We have fulfilled the mission of why this program exists. Thank you.